So welcome to the part 2 of atrial fibrillation. In this video, we are going to do the management and the drugs for that are used for rhythm control and rate control. So starting with that, we have the rhythm control. So most of the times, rhythm control is not tested in the cases of when AMC tests you for the atrial fibrillation. So AMC do not usually test for rhythm control. Mostly they check you for the stroke Chadwick score and anticoagulation when you are going to go for the anticoagulation and the rate control. But we have to do the rhythm control also. So, acute rhythm control is indicated when the patient is recently diagnosed atrial fibrillation and it is for less than 12 months, and the patient remains asymptomatic despite the rate control, and there is decreased left ventricular ejection fraction. Now, first we have the electrical cardioversion. So, electrical cardioversion is to control the rhythm, and it contains the DC cardioversion and it requires procedural sedation. Then we have pharmacological cardioversion. Pharmacological cardioversion, first line we have the flecainide drug, that is flecainide. So flecainide is indicated when the ejection fraction is more than 40% and there is no significant coronary artery disease. But if the patient has decreased ejection fraction or equal to 40%, or he has coronary artery disease, we are going to go for the amiodarone for rhythm control. So there is another thing that is called as the pill in the pocket, and this is a single oral dose of flecainide to restore sinus rhythm, and it can be self-administered. And it is for the patient who have infrequent episodes of atrial fibrillation. And flecainide dose is usually best taken in combination with the single dose of AV nodal blocking drug, that is beta blocker, diltiazem, verapamil, to decrease the risk of conversion to atrial flutter. So, if there is an increased risk of conversion to atrial flutter, we can give the flecainide in combination with these drugs. Now, for long term rhythm control, there is the catheter ablation, and consider early referral for a catheter ablation. And the outcomes are better if it is performed in less than 12 months from the diagnosis of atrial fibrillation. So, the patients who have recently diagnosed atrial fibrillation and it is the duration is less than 12 months, we can consider them for cardiac ablation earlier, because earlier the cardiac ablation, catheter ablation, the better outcomes would be there. Now we have the long-term control, pharmacological long-term control through sotalol. Number one is sotalol in patients with coronary artery disease and left ventricular function is normal. So we are going to go for the sotalol, and it is avoided in severe kidney impairment. So first we have done the acute rhythm control. And acute rhythm control, there were two drugs, flecainide and amiodarone. But for the long-term control, we have the catheter ablation and this pharmacological treatment. So number one is sotalol in patients with coronary artery disease and left ventricular function is normal, and it is avoided in severe kidney impairment. But the main side effect for sotalol is QT prolongation, and we have to stop the sotalol if it is more than 0.5. QT prolongation is more than 0.5. Then we have the flecainide. Flecainide is considered when the left ventricular ejection fraction is more than 40 and there is no coronary artery disease, and a structural heart, if the patient has a structural heart disease or atrial fibrillation. But it is associated with flecainide is associated with fatal ventricular arrhythmia. Now, if one and two, yani कि, if one and two, sotalol and flecainide, both of them are not suitable due to their comorbs, we are going to go for the amiodarone. But the side effect for amiodarone is when used in long term is the serious lung and thyroid and liver adverse effects long term. In the long term, so we have to monitor the LFTs and thyroid profile, liver function test, and thyroid profile when the patient is on long-term treatment with amiodarone. Then we have the rate control, and for rate control, we have to aim for the resting heart rate of less than 110. Number one, we have first line drugs for rate control of atrial fibrillation. In rate control in atrial fibrillation is the beta blocker. And if the ejection fraction is less than 40, we are going to use the heart failure specific beta blockers, that is bisoprolol and other heart specific beta blockers. Then we have the non-dihydropyridine calcium channel blockers. If beta blockers are contraindicated or not tolerated or suitable, we would go for this and avoid diltiazem and verapamil and diltiazem are in this group. And we have to avoid these drugs if ejection fraction is less than 40 because it has the negative ionotropic effects. On the third, we have digoxin, and digoxin is used when the diltiazem, verapamil, or beta blockers are failed or contraindicated. That is, if the patient is of atrial fibrillation and heart failure. In both of these, the beta blockers and calcium channel blockers get suspicious and we have to give them cautiously. So digoxin can be used. Then we have the amiodarone. If all other drugs are contraindicated, then we are going to go for the amiodarone, and it is usually for the short term. Now, for urgent rate control, if the patient urgent rate control is indicated when there are significant symptoms and it is given under the specialist care, and metoprolol, esmolol, or verapamil can be given IV. But the side effect of verapamil IV can is that it can cause a depression of heart rate, and especially if the patient is on beta blockers or there is a previous myocardial disease. And if all of the above drugs, esmolol, these drugs are not suitable, we can go for the amiodarone for urgent rate control. So that's it for the management of atrial fibrillation. Hope you have understood the topic of atrial fibrillation. It is very important. You have to learn the Charva score and when you are going to give the anticoagulation therapy and when you are going to go for the rate control. So these are some of the very important points you have to keep in mind. So that's it for atrial fibrillation. Thank you.